Well, thank you. You're going to see at least half of my talk. I'm assigned to talk about botulinum toxin, but it's been around for almost 30 years, and most of you combined have many decades of experience with botulinum toxin. There's not too much more to be said about it. But I do have a couple of points to make. Let's try with this. This colorful lady was the very first person to get botulinum toxin for her blepharospasm. You can see her eyes are open now, but at that time she was really housebound. It was pretty interesting. I hadn't the faintest idea what dose to use, except that having used it in strabismus, it seemed like a good idea to put 10 units right in the middle of the eyelid there, and she called up the next morning and said, ecstatic, "My eye is open." The next day she called up and said, "My eye is closed." So we very quickly learned over a short period of time really pretty much how to use botulinum toxin. And I guess, what's advanced? This one? This one? What do you do? The one on the side? That's what I thought I did. There we go. So I'm going to talk briefly about that, and then I'm going to talk about a couple of new treatments. There are sort of three major parts of blepharospasm which involve the eyelid closing muscle, the orbicularis muscle. Makes the eye blink. It creates intermittent spasm, and then for some people, tonic spasm. And we've heard about avoiding irritations, things about dry eyes and so on. Medications for a few patients will be discussed later, as will surgery, and toxin injection blocks the orbicularis action. And I have only one thing to add. I see occasional patients who aren't getting good effects from botulinum toxin. And the procerus muscle and another similar muscle that goes from here up to here and pulls the brow down is a major player in creating eyelid closure, and it doesn't get injected by many people. If you put a wad of toxin right here, I usually use about 5 units to start, and another one down here, it will diffuse over into the procerus muscle and much improve the effect that's got. If you try and inject it directly here, there's an eye muscle back in here which occasionally gets paralyzed and you see double, so that's not such a good idea. The second point I want to make is that injecting right down here along the lid, there's a muscle that has a name, Rieland's muscle, but the point is that there's a lot of tissue in here and that muscle's woven in through that. And so injecting up here in the lid someplace doesn't always allow it to diffuse down there, and it needs to be injected in that place. I do want to point out that toxin types are changing. We had Botox alone in this country for a very long time. The FDA has now given it some special names that you might sort of run across. Botulinum toxin, and some others don't think that they're new toxins, they're simply new names. But this is a toxin type that comes from the UK. It will be here shortly, if not already. Myoblock you know about, which I think is not quite such an interesting toxin for blepharospasm, but it hurts when you inject it underneath the skin. But others coming from Europe, Xeomin's coming, the University of Wisconsin has a toxin type A that's coming, and there are unlicensed toxins that are starting to show up. If you look on the internet, you will find that here's a Botox, which you can buy someplace over in the Hong Kong region. It's got 100 IUs in it, whatever those are, and it costs $100, a pretty good deal. And you should be very, very careful of these things. Each one of the potency tests for toxin costs at least $1,000, and it costs it takes many of them just to qualify one of these lots of toxin. And the people who are doing this kind of thing, so Don't jump on the airplane, 3 or 4 of you together, and send somebody over to buy cheap Toxin somewhere. You'll be in trouble. So besides the orbicularis, which closes the eye too much, the levator, which lifts the eye, doesn't work sometimes very well. And all of these things that we find that work for blepharospasm in general, they help because the levator now doesn't have to work against them because we've taken away the spasm that closes it. So there are a number of things that happen. Surgery is really the main one because eyelids just get stretched, closed, and they need to be elevated up. But we found that here's a new thing that we can try. We can inject this stuff which will strengthen the levator muscle. So the levator muscle is stretched, the lid droops, and Bupivacaine is a local anesthetic. It's just a standard local anesthetic. It's been around for years and years. It has a special property, just as Botox has a special property. It involves only the nerve endings. So beyond its local anesthetic property, Bupivacaine has this ability to damage the myofibrils in the muscle. The muscle's left intact in all other ways, and the cells regenerate the muscle, but they don't seem to know when to quit, and so the muscle is now bigger and stiffer and typically a little bit shorter. If you take a muscle which normally has a perfect structure like this and inject this stuff, this is what happens after a couple of hours. The little connectors that should be making all of these things line up perfectly are dissolved out, and this muscle is damaged and has to be replaced. So there's damage, there is then regeneration, and then there is hypertrophy. This is in a young rat, so the normal side is growing a little bit, but the injected side gets bigger. And also note this, that it is very stable over a long time in effect. So here's a young man who was operated upon for his very large amount of strabismus and had a very large amount of surgery, and he's still not lined up at all. He wasn't too thrilled with having more surgery done, so he was willing to have us inject his muscle on the inside here, right? Because this is the muscle we want to have become stiffer, shorter, stronger, and hold his eye in. And here he is 18 days after injecting Bupivacaine, that local anesthetic in here. And we also put a little bit of Botox, not very much, just to relax this muscle on the outside so there wasn't any stretch, just kind of pulling all the time. And here he is 3 months later, and we've seen him now 6 or 8 months later, and he's still fine. Here's a muscle, which has, well, here's a normal muscle over here, and here's a muscle which has been exposed to Bupivacaine several years before, and you can see the muscle fibers are bigger. If we do this to patients, we see that pretty uniformly, they all get bigger muscles. It drifts off a little bit, but they all get bigger muscles, and it's pretty stable for hundreds of days. So if you take people with their eye turned and inject them, they started up here, but then they wound up down at a lower level. And again, it's permanent for a very long time. So what about doing this for somebody who has blepharospasm? This is a MRI picture. If you took my eye and sliced it right down here and looked at it from the side, my forehead would be up here, and my eye would be here. My cheeks and teeth are way down here someplace, and this cuts right through the eye, and it cuts through the muscle that lifts the eye up here, the superior rectus, and right next to it is this levator muscle. So using a special technique with an electrically controlled EMG needle, just as we do for some eye muscle things, you can inject this muscle preferentially and blow it up here. And so here's a gentleman who has apraxia. He has a levator problem. He's had a myectomy. You can see a scar up here. He's had a levator muscle shortening operation to lift that muscle and tighten it. And he's had Botox, and here he is. He can just get this eye open enough to see, and he can't get this one eye open enough to see, and he could hardly work. So here he is 26 days after Bupivacaine to this eye, clearly better, because he's into the regeneration and hypertrophy level now, and he has this now shorter, stronger, and stiffer muscle holding up his eye. And he said, well, do the other one, Doc. So here he is. This is now 130 days, and this one is, 42 days or something like that after here. So this is a useful treatment for people who have apraxia, this problem where there's no more spasm, they just can't get their eye open. And there's a number of you out there that I'm sure have that problem. Another thing that we're thinking to do is, can we, in patients who just can't keep their eyes open, can we not stimulate the muscle to hold the eye open? And the answer is yes, it looks like we probably can. The idea is to stimulate the nerve to that muscle that lifts the eye just a little bit. Doesn't take much, just like that gentleman you saw. And we turn it on for about 8 or 10 seconds. That's what most of us do. We keep our eye open for 6 or 8 or 10 seconds, then we blink it. The electrodes are easily implanted, and we've had this in rabbits for long periods of time. This is the design of this little thing. You can see that it's about 2 millimeters. It's about 1 centimeter long, because we need to have something to hold on to push it back where it needs to go. This is the stimulus generator. It's about as big as a credit card, and this is 8 channels, of which we will really only use 1 or 2. So the thing that we'll use will be just a little tiny bit of this, plus a small battery, and then a radio frequency charging circuit. So we'll be able to implant this in the area right up here by the orbit, we think. Here shows about the area of the actual thing that we'll be using, not just this entire experimental chip. With any luck, and I'm not sure we're having luck, I was going to show you the, you think it's coming? Good enough. I want to thank Dr. Ostrom, who is the, I guess, co-author of this, which will show us what's happening. So here's a rabbit that has one of these implanted, and you can see that his lid, we're only stimulating for brief periods here, but the eyelid lifts and goes down. Lifts and goes down. Here's a few weeks later, and we need to make this thing work over long periods of time, and here we are again, up, and we will be doing this for slightly longer periods than a few seconds or 1 or 2 seconds here. And then here we are a year later, because we need to test out this electrode. You can see he's grown a luxuriant coat of rabbit fur, and he can lift his eye when stimulated through these electrodes. We will, with this new system, have an implanted device here. So there's a handful of people for whom Botox is not enough, and for which it's possible to tighten up the levator. It looks like it's going to be an effective way to go. And I think it's going to be interesting to see over how many muscles areas that approach is going to be used, because it's potentially widely useful. And also, Functional electrical stimulation, it looks like it'll be a small operation and not a big thing to do. It takes a few minutes to implant these electrodes in a rabbit, and it would be about the same in humans in a while. Thank you.